أول حاجة I would like to thank so much Professor Nada for inviting me. Nada need nothing to be said, and I think it's not a rising star. See, she is a star already. I also extend my kindness to Professor El-Khayyat for her invitation, and I would like to welcome all of you, commentators, advisors, and moderator, and especially Professor Stephen, because we have him many times in Tidor Belhars Research Institute. I'm speaking so basic. Asked me, Dr. Nada, to speak very basic, because this presentation is going to the young generation, so I'm not going in depth in management of upper GI bleeding. This is my disclosure, and this is my main reference, which I alluded in my presentation. The Bavino, ACG, ECG, and the British Society of Gastroenterology. So I'm going to my target because of time. The common cause, as we know, of upper GI bleeding is variceal bleeding, which is common in our country, peptic ulcer bleeding, gastroduodenal erosion, and Mary-Wise tear, and angiodysplasia AVM, Dieulafoy lesion. Please be considered Dieulafoy lesion, especially in gastroesophageal junction, because we see a lot of cases in the last 10 years in our institutes, and you have to deal with it because it's sometimes giving massive GI bleeding. Malignancy can be presented with bleeding as well. The variceal bleeding usually is abrupt and massive. Underlying cirrhosis and portal hypertension is the cause. Sometimes in portal hypertension, the bleeding coming from erosive gastropathy and peptic ulcer. And in peptic ulcer, the bleeding is coming from other gastric or duodenal. Also, non-steroidal is playing the most important role beside H. pylori and acid hypersecretion, and the history of peptic ulcer suggestion can be alluded to. It's important for all of us, and especially the young generation, to have a risk assessment. We have a lot of scores. I will not go through all the scores. I use sometimes the AIM 65, which is 5 scores, and it indicates massive mortality because it alluded to the prognosis. If we have 5, the mortality rate become higher. Now I would like to stratify the upper GI bleeding into variceal and non-variceal. Let us speak about non-variceal upper GI bleeding. The cause, as I mentioned before, many, as you see, peptic ulcer, malodorous, erosive esophagitis, malignancy, AVM, Dieulafoy, and other causes like hemophilia, stomal ulcer, and vasculitis, Kaposi sarcoma, as you see in these slides. Of course, my presentation is alluded more to endoscopic management, but please, before endoscopic management, you have to resuscitate, assess, giving BBI in a dose, as I will mention later, and endoscopic coming is important, but beside endoscope, you should resuscitate and assess your patient and give BBI. Radiological management is considered if endoscopic management is failed. The proton pump inhibitors should be given in 80 milligram bolus, as we all know, and then followed by 8 milligram per hour. Non-variceal upper GI bleeding, role of endoscopy is not for diagnosis and management or therapy, but also it predicts rebleeding and mortality. And usually we do endoscopy in our endoscopy suite between 12 and 24 hours after resuscitation and evaluation of our patient. As we see in these slides, we see the NSAID-induced ulcer. Sometimes this is first 2C, because there is pigmentation, pigmented clot. As we usually speak the same language, we should allude it to forest classification, because this will direct therapy and direct as well prognosis and rebleeding, as we see in these slides. Of course, forest 1, it usually comes with rebleeding in 55% if you don't have endoscopic management. In forest 1A, spurting or oozing, we used 2 techniques. Since the early 2000, we know very well that injection of adrenaline is not sufficient. We have to do either clipping or thermal ablation. Forest 3 and Forest 2C, we don't need to do any further except the infusion of BBI. Endoscopic management, we have many tools, and we should, if you deal with any upper GI or lower GI bleeding, you should have all these tools or armamentarium in your endoscopic suite, starting from injection needles and adrenaline, thermal ablation, ABC or heat probe or bicap probe, mechanical clipping and band ligation. Hemospray is important, because if you fail or if you have a massive bleeding, hemospray is important, because hemospray is in an iron mineral inorganic powder that when it comes with any fluid or blood, it causes an adhesive layer that stop the bleeding. Of course, combination of all above modality is important. You should have all this in your endoscopic suite if you deal with any GI bleeding, starting from heater probe, ABC, banding, endoscopic injection, and rotatable, controllable clipping, and the hemospray in the last. Usually in the Dieulafoy lesion, if we face it in our institute, before we use injection together with thermal application, but we have a very massive bleeding, because as you all with thermal application, because as you all know, Dieulafoy lesion is vascular lesion coming from the submucosa to the mucosa and cause massive bleeding. If you apply heater probe or OBC first, you sometimes make erosion to the vessel and cause massive bleeding. What we use in Theodore Bilharz Research Institute, usually we do injection and bending. So failure to control, we have either radiological, and rarely we send the patient to surgery. The take-home message for non-varicose upper GI bleeding: before you go to endoscopy, please risk assessment, resuscitation, IV BBI, and later test for H. pylori and give treatment. Management of acute varicose bleeding, which is important in our country. Again, initial evaluation is important. Resuscitation, transfusion policy is important. Vasoactive drug, instead of BBI, we have terlipressin and somatostatin. Antibiotic therapy is important in this situation. Endoscopic diagnosis and therapy come later on, within 12 hours of admission of our patient. So initial evaluation is important, as I mentioned, and resuscitation is more important, because we have to gain 2 peripheral venous line. Central venous access sometimes important. You have to protect airway, especially if you have severe bleeding, severe encephalopathy, and inability to maintain oxygen pressure more than 90%. Transfusion, you have to keep the hemoglobin level between 8 and 9 grams per deciliter, not more, to prevent further bleeding. Vasoactive drugs is important with antibiotic, as I mentioned before. Terlipressin is important, more important than somatostatin, but the problem, we use somatostatin more because trilipsin is a little bit more expensive, and the actual dose or the right dose 2 milligram per 4 hours IV. So we have to use 6 ampoule for every day. Vasoactive.
The vasoactive drugs in suspected varicella bleeding, vasoactive drugs should be started as soon as possible.
I don't need any further. My voice is loud, so vasoactive drugs is important. Antibiotics prophylaxis is important. Why? Because cirrhotic patients are at increased risk of infection, bleeding increase the risk of sepsis, hemorrhagic shock also increase bacterial translocation. And what should we use? We don't use oral quinolone except for prophylaxis of spontaneous bacterial peritonitis. But we usually use in our department intravenous ceftriaxone. This is more potent than quinolone because oral quinolone cannot be used especially in massive bleeding. Sanguine tube can be used, but usually we don't need it except for massive bleeding. Endoscopic diagnosis and management should be done within 12 hours of admission of our patient. Of course, endoscopic band ligation is a recommended form of treatment in esophageal varicella bleeding, and sclerotherapy can be used still. We need sclerotherapy if there is ligation is technically difficult, but usually we use endoscopic band ligation. Of course, tissue adhesive histoacryl with lipidol 1:1, what we call it glue, is used to inject gastric varices. And since I was in the state till now, since 30 years, I was in Harvard Medical School, Beth Israel Hospital. Still till now, I think it is not approved by FDA, right? This is band ligation esophageal varices. This is the glue we use to inject histoacryl 1:1 to lipidol till we palpate the vessel, the fundal varix, and we see it hard, as well as we see like the last pictures, the glue coming out from the injection site. New approaches, tips, of course, one of the approaches, it can be done, and we used to done it in some cases in our department, in our institute. Self-expanded metallic stent also can be applied in severe bleeding, and the hemostatic nanopowder, it's like hemospray, also can be done. This is in severe bleeding, self-expandable metallic stent, and then after that removed, and then we dealt with our patient. So the take-home message for varicella upper GI bleeding, risk assessment is important. AIM 65 score as well as child buccal score. Resuscitation, blood transfusion, please don't give more blood and don't raise hemoglobin above 9. Vasoactive drugs, trilipsin is more effective than somatostatin, although we all use in our institute somatostatin. Endoscopy within 12 hours. Other methods can be used if there is severe bleeding. Secondary prevention is mandatory. Don't leave your patient after going out from your hospital without secondary prevention, and schedule it. Multidisciplinary approach is mandatory, and I thank you so much.